Epilepsy. Let's talk about epilepsy. More than 2 million people in the U.S. have recurrent seizures. There's primary and secondary. Primary is idiopathic. There's no known cause. And that's more than 50% of the epilepsy cases. Secondary, there is a distinct cause. Could be trauma, could be infection, or a cerebrovascular disorder. Could be a tumor. Epilepsy itself is not a disease. Epilepsy is a syndrome or a symptom of diseases. We treat the symptoms when we treat epilepsy, but we're not treating the disease. So we have to make sure that's really clear. People have epilepsy, but they don't have an actual disease called epilepsy. They have seizures that are either related to something else or have no unknown cause. So you identify seizures based on abnormal EEGs, electroencephalograms, abnormal motor function, loss of consciousness, and interference with sensory function. What causes seizures? A lot of things. Increased intracranial pressure, CNS infections, fevers, tumors or cysts in the CNS, head trauma, withdrawal from barbiturates or alcohol, severe hypoxia, and hypoglycemia. Identification of the cause of the seizure activity is important in determining the type of therapy that is required. The goal of the therapy is to reduce the frequency of the seizure activity and minimize the adverse effects of the medicine. If you can identify the cause, you can also eliminate the seizures. So, risks within the special population. A quarter of the children with mental retardation of some form have epilepsy. And you can see just the list of all these special populations that have a higher than normal chance of having epilepsy or seizures of some sort. Now there are different types of seizures, partial and generalized. And the partial seizure could be simple partial or complex partial. Simple partial, there's no loss of consciousness. Complex partial, there is some impairment of consciousness. Generalized seizures can be broken into convulsive and non-convulsive. Tonic-clonic seizures are the classic grand mal seizure. A sudden cry, falling, rigidity followed by muscle jerks, shallow breathing, temporary apnea, possible loss of bladder control. These last a couple of minutes. Some people describe an aura just prior to the seizure. Following the seizure, the client usually sleeps soundly for a period of time. That's called the post-ictal state. Seizures, if you've never seen one before, grand mal seizures can be very scary. They are really profound. And what we're going to try to do is protect the person from hurting themselves. That's it. In Wisconsin, by the way, if a person in Wisconsin has seizures, they're not allowed to drive for 6 months until 6 months after the last seizure. So that's an important, do you want somebody who has recurrent seizures driving? It would be a problem. There are other types of seizures. Febrile seizures are very common, especially with children. High fever and suddenly they just start seizing. Treat the fever, seizures go away. Status epilepticus is a seizure that will not stop. I've never seen one of those. I've seen grand mal seizures, partial seizures, and my son had a febrile seizure. Scariest thing I've ever seen with my son. I was holding him and he was just like seizing in my arms. That's what happens when you're a parent. Assessment. As always, we want a baseline. We want to know what the person is like before there's a seizure. So what's their mental status? What's their level of consciousness? What kind of history do they have? What does the EEG say? What's their additional health history? Were they in a car accident where they struck their head? Did they have cancer previously, and could it have metastasized? A lot of health history related questions. Do they have drug allergies? Cardiac, renal, liver function studies, CBC, and just as always that baseline set of vital signs. Now, anti-epileptic drugs, there are many categories. Sometimes anti-epileptic therapy is lifelong. Sometimes it's until the underlying condition is treated. Commonly, doctors will use a combination of medications to control the seizures and minimize the side effects. Anti-epileptic drugs usually used only after 2 or more seizures, and they're selected based on the type of seizure. Now, they may only use one, or they may use multiple drugs, and usually they'll start with just one. And if that doesn't control it, they'll add a second or a third, or then they start titrating with different drugs to find what works for that person. These drugs have a very narrow therapeutic index, and because of that, they need to be given at the same time every day. They need very regular dosing, and that's an important patient teaching, that if they take their medication at 8 o'clock in the morning, it needs to be taken every morning at 8 o'clock. If you drop below that therapeutic level, you are at risk of having another seizure. They can be teratogenic, and they also can alter enzyme metabolism. Sudden stops, the other important thing is they cannot suddenly stop these medications because it will trigger seizures. So we have 2 types of anti-epileptic drugs, conventional and newer. Conventional, phenytoin or Dilantin is very common. Carbamazepine or Tegretol, phenobarbital, that's a barbiturate, we talked about that earlier, and valproic acid or Depakote. Those are very commonly prescribed. Always continue even after the seizures stop. These medications do cause increased drowsiness. Sudden stops of any of the conventional anti-epileptics can trigger seizures. What if the patient can't swallow? I mean, for whatever reason, they're unable to swallow these pills. What will you do? Obviously, or maybe not obviously, you have to report that to the doctor. That's a critical thing because that will affect their ability to take it on a regular basis. There are also newer anti-epileptics. Keppra, Neurontin, and Topamax are newer medications. So let's talk about barbiturates a little bit more. We talked about those earlier. Phenobarbital is common, and it produces CNS depression. So it decreases the sensory cortex, decreases motor activity, alters cerebellar function. It's an anticonvulsant. So if a person has, and that's why they're using it, for partial and generalized tonic-clonic seizures. And it can be used prophylactically in control of febrile seizures. This is a long-acting barbiturate, once-a-day dosing. It is the most expensive anti-epileptic drug. I'm sorry, most inexpensive anti-epileptic drug. It's been around a long time. It interacts with many drugs because it's a major inducer of hepatic enzymes which cause more rapid clearance of some drugs. Because of the sedative effects, they're used as an alternative. Barbiturates are not usually the first-line treatment. Side effects, as we've covered before, lethargy, sedation, drowsiness, paradoxical restlessness, excitement sometimes, Stevens-Johnson syndrome. Important thing is, remember, these drugs have an additive interaction with other CNS depressants, specifically drugs, opioids, sedatives and hypnotics. So we want to, barbiturates are used very carefully. Hydantoins, most common is Dilantin or Cerebrax. These are the most commonly prescribed anti-epileptic drugs in the U.S. They're well tolerated, relatively inexpensive. Once or twice a day dosing, they have a long half-life, and they're available both in IV and oral forms. And that's important if a person can't swallow, because we can give these IV. And because they have a long half-life, it makes for more stable therapeutic levels. Exaggerated phenytoin effects can be seen with patients with low serum albumin concentrations. This could be a person who's malnourished, chronic renal failure, potentially alcoholic. So if they have low serum albumin concentrations, we need to improve the diet, maybe even give some albumin piggybacks. We need to do blood level monitoring because it has a very narrow therapeutic index. We need to reduce sodium intake reduces the sodium intake to hyperactive neurons by inhibiting sodium channels. These can also be used to treat certain dysrhythmias. These are bound to plasma proteins, so we must monitor free, unbound drug levels. It depletes folate, B12, D, and K. So multivitamin is very important. It's teratogenic because of the folate depletion. And what happens when a mother doesn't have enough folate or folic acid? Neural tube defects, spinal bifida. It can cause gingival hyperplasia, or overgrowth of the gingiva, which can be prevented by taking folate supplements, oral rinsing, and good oral hygiene. And it causes CNS depression. So of course we must avoid alcohol and all other CNS depressants. Side effects, similar to many others: lethargy, abnormal movements, ataxia, mental confusion, cognitive changes, and dizziness. We must check phenytoin levels to ensure therapeutic index because it's such a narrow therapeutic window. Going to watch for skin rash and Stevens-Johnson syndrome. Again, that gingival hyperplasia, and coming up there will be a picture of what that looks like. Concurrent administration of enteral tube feedings may decrease phenytoin absorption, so we need to make sure that we let 2 hours go by between feedings and the phenytoin administration. This is something you do not take with food. We again have to monitor phenytoin levels for toxicity. Good dental hygiene. Different brands of phenytoin may not be equivalent. We talked about that in, I believe, the first exam. So once a person reaches a therapeutic effect on a phenytoin brand, they need to stay on that brand. This may color the person's urine pink or reddish brown, but that's completely insignificant. And of course, we will monitor blood glucose very carefully. They need very good dental care, both at home in terms of their own care and visiting regular dental visits. The aminostilbenes, carbamazepine, or brand name Tegretol, these decrease the synaptic transmission in the CNS by affecting sodium channels in the neurons. Again, used in conjunction with other anticonvulsants to control partial seizures. This is the second most commonly prescribed after phenytoins. And this is very closely related to tricyclic antidepressants. Available in oral forms. You need to reach your therapeutic index and get and labs need to be approximately 8 to 12 micrograms per mil. That's the lab value we're looking for. Same mechanism as phenytoin though. Similar side effects, but fewer. Grapefruit juice increases the peak and trough levels by 40%, so no grapefruit juice. May cause a skin rash. Hepatic failure, it's also teratogenic. We're going to monitor serum sodium, or Na+, that's sodium ions, complete blood count, liver enzymes. This is the drug of choice for partial seizures, but it's ineffective for generalized seizures. It's also used for bipolar and trigeminal neuralgia. So this has a wide variety of uses. So if a person's on Tegretol, do not assume they have seizures. They might, but they could have other problems too. Side effects: nausea, vomiting, drowsiness, dizziness, reduced by slowly decreasing the dose. We need to monitor daily weights if the person has heart failure. We need to check lung sounds and watch for edema. Should not work around machinery while taking these. They can cause drowsiness. And again, monitoring the CBC, platelet count, BUN, and liver enzymes. This can cause bone marrow suppression. So that's what the CBC is for. Valproates. Is the next category. Depakote is the brand name. Valproic acid is the generic. This increases the levels of GABA, G-A-B-A, which is an inhibitory neurotransmitter in the CNS. This is used in conjunction with other anticonvulsants, controls simple and complex partial seizures. Some of the side effects are similar to all the other medications, but also have suicidal thoughts and sedation, confusion, visual disturbances. This interacts with other CNS depressants such as antihistamines, alcohol, analgesics, tranquilizers, other anticonvulsives, sedatives, and hypnotics. So this drug we use carefully because there's so many other interactions. It increases the level of warfarin. What lab are we looking at with warfarin? Protyme INR, PT-INR. Succinimides is the next category. Zerantin is the brand name. Ethoxamide is the generic. They don't know how this works. It's used in treating absence seizures, where the person is essentially just staring into nothingness. Safe and effective first-line agent for absence seizures. These seizures most commonly happen in childhood. So this is a medication we'll be giving to our juvenile patients. It may be added to other agents such as valproic acid when it cannot control generalized epilepsy. An indication for which is an indication for adults. It can cause hematuria and urinary frequency. CNS, some major CNS effects are night terrors and aggression. And it can cause blood dyscrasias, so we're going to be monitoring that CBC on a regular basis. We'll also take this with food or milk to reduce gastric irritation. Sedation will disappear with continued therapy, but they should not use machinery until all the effects are known to that person. Benzodiazepines are also used sometimes. Valium, very commonly. That's used for all forms of epilepsy and status epilepticus. Remember, a seizure that doesn't quit. We can also use lorazepam or Ativan. These are both good benzodiazepines. And again, if a person is has a status epilepticus event, you'll be giving Valium. Orally? No, not orally. You're not going to try to put a pill in their mouth. This can be given IM, IV, or rectal for anti-seizure activity. You don't mix the IV diazepam with any other medications because precipitate will form. Klonopin is the most widely used oral benzodiazepine in the U.S. Side effects, we've talked about benzodiazepines earlier in this lecture. Sedation is a big one. Lethargy, headache, dizziness. It can cause physical and psychological dependence. And like with many medications, additive effects with other CNS depressants, including alcohol. Rapid withdrawal of long-term use may result in symptoms similar to alcohol withdrawal, weakness, anxiety, delirium, grand mal seizures, but may not happen until several days after the discontinuation, just like alcohol. Alcohol usually takes about 48 hours before the withdrawal symptoms are triggered. Anti-epileptic drugs in general. Take regularly at the same time of each day. Take with meals. Use a daily journal to to record your response to medications, both good responses and bad. Record seizures and have a description of the seizure, including the length of the seizure. What side effects are you noticing? You should be wearing a medical alert tag or an ID tag because of all the side effects and interactions with other medications. Consider alternatives to hormonal contraception. Do not drive until seizure-free for 3 months or 6 months in Wisconsin. Do not take with alcohol or other CNS depressants. Do not discontinue abruptly, and therapy is long-term and might last forever. But 75% of people who are seizure-free on medication for 2 to 5 years can be successfully withdrawn from medication. Others, the other 25%, will be on permanently. Next topic will be Parkinson's.